I'll be speaking on surgical management of vitreomacular traction. So pathophysiology already Dr. Raja Narayan has gone through. So most of the time there's a normal PVD and there are no symptoms and the PVD gets detached from the retina in a normal way. But when it doesn't happen, that is known as anomalous PVD. So there is a persistent adhesion between the vitreous and the ILM, but there is syneresis. So there's a vitreous is moving and this can cause multiple problems. You can get a HST in the periphery, you can get a vitreomacular traction, you can get a macular hole, or you can get a ERM. So these are all the various gamut of clinical representations that you can get because of anomalous PVD. So first we'll go to the definition, or what do we mean by vitreomacular adhesion. So vitreomacular adhesion means that there is an attachment of the vitreous at the foveal area and the patient is asymptomatic and the OCT also is normal. So this is known as vitreomacular adhesion. And what do we mean by vitreomacular traction? This was a term coined by Rees et al. In 1970 and it was diagnosed or it was confirmed by histopath. It was not a diagnosis based on the imaging. So there is a persistent vitreoretinal adhesion at the macular area in the setting of a partial PVD. And there are obvious changes on the OCT and the patient most of the time may be symptomatic. So here you can see the vitreous is attached to the foveal area. There are cystoid changes in the macula. So this is known as vitreomacular traction. And once you diagnose VMT, then what next you do? You try to see whether it is idiopathic, whether it is associated with any other ocular problems. If it is associated with other ocular problems or it could be associated with ERM, diabetic retinopathy, ARMD, then it is known as concurrent VMA or concurrent VMT. Why it is important? Because such patients may respond suboptimally to the medical management. Like if there is a ERM associated with CRVO related macular edema or diabetic retinopathy or with VMT, these patients may not respond very well to the anti-VEGFs. So this you may have to counsel the patient that a course of anti-VEGF is advisable, but ultimately in future you may need vitreous intervention also. So this is important at the initial step only to tell the patient. And the other importance of morphology is if there is the vitreous is attached in a narrow funnel, there is a greater tractional. You can see the vitreous is attached in a narrow funnel. So the vitreous movement, the eye movements is going to exert more traction. So these patients are likely to have more changes on the OCT. They are going to be more symptomatic. The visual loss also is going to be more. And they will have more structural changes as compared to the broad attachment. Here the force is distributed. The tractional forces are distributed beyond the fovea. So the anatomical changes right at the fovea will be less, but you can get a diffuse retinal thickening. And these patients, once you operate, there will be poor recovery of foveal depression. And most of these patients may have associated ERM. The presence of ERM is important because the VMT will cause anterior-posterior traction and the ERM causes tangential traction. So both will play a part. And the partial PVD can cause splits in the ILM, allowing glial cells to gain access to the superficial retina and to the back surface of the detached posterior vitreous. So here you can see the IPVD has caused defects here, and through this glial cells are going on the ERM along the and also on the posterior surface of the vitreous. And ERM prevents spontaneous separation and increases the tangential traction. We all know that PVD, the IPVD can sometimes, it can just improve on its own, it may detach. But if there is a presence of ERM, then the chances will be less. So before tackling VMT, we should know the natural history. So in this study, 106 eyes with VMA were followed up for 18 months and the author divided into various grades. Grade 1 was incomplete PVD with attachment at the fovea. Grade 2 was grade 1 plus any intraretinal cyst. And the grade 3 was grade 2 plus the presence of SRF. And on follow-up, release of vitreomacular adhesion was seen in 32% of the cases, 30% in grade 1, and 57% in grade 3. So with time, a lot of these additions can release on their own. And no changes were observed in almost 52% of the cases. And progression occurred in 16% of the cases. So many of the patients may have quite bad looking OCT, but if the patient is asymptomatic, vision is good, they can definitely be watched. And once the patient is symptomatic, then you may have to operate. So this is the same thing, that spontaneous complete PVD can occur, and poor or worsening visual acuity requires treatment. And the visual acuity improves in 48 to 78% of such cases. So proper case selection is a must. This is a case of 76-year-old male. The patient had 624 vision, and this is the OCT. So looks very symptomatic, and the patient's vision was less. So he was given the option of vitreous surgery, and this is the post-op results. Within 2 weeks, there was good improvement. So in such cases, you have to be careful that while inducing PVD, you don't exert too much sort of pull. Otherwise, you can create a full thickness hole. In such cases, you have to be gentle, or you could leave the vitreous that is attached at the foveal area. You can do an ILM that is foveal sparing. So you have to be careful in such cases. This is a case 2, 65-year-old male, underwent cataract surgery 6 weeks back, vision is 612, the FR is dull, and this also there's a focal attachment with cystoid changes. But the problem is, now we are not sure whether this patient has post-surgical CME or tractional CME, because the patient has undergone cataract surgery also. So in such cases, there's a role for FFA. So if you look at the FA, so you don't see the disc is okay, there is no staining of the disc, and the leakage pattern also is not like the typical post-surgical cystoid. So this is more because of the tractional. So here you could counsel the patient for vitrectomy, because this is not post-surgical CME. So this you cannot diagnose just based on the OCT. You need the help of FFA. This is another case, 70-year-old female, the left eye 624, hypertensive, old BRVO, underwent cataract surgery 2 months back, and this is the OCT picture. You can see a thick ERM with cystoid edema. So here also you are in a dilemma what to do. So you can see a sclerosed vessel there, old BRVO, and this is the FFA. Now if you look at the FFA, this leakage is typical of the BRVO, vascular. It is not because of the tractional. So the FFA plays a part in our management. And this is a small video that shows the importance of the PVD, because all these patients, the problem is because of the attached vitreous. So you have to be thorough in the vitreous removal. A gentle PVD is a must. You can stain the vitreous and do the PVD. And you have to always look at the periphery. And in this case, the vitreous was very taut, and you can see the folds occurring when you are trying to engage the vitreous. The PVD is being induced. And you should not hesitate to use Orocort, because vitreous PVD induction is very crucial in such cases. And this also shows the ERM being removed. ERM does not get very well stained with the brilliant blue. So there are two options. One is that you can peel the ILM after staining with the Orocort, or you could try to peel the ILM. And once you peel the ILM, the ERM which is lying on top of that, it is going to come out on its own. So, and with the availability of forceps, the ILM peeling has become quite easy. This is a, I think, diabetic patient who underwent ILM peeling. I just go to the next. I think we are running short of time. And it is very important to know when you decide to operate a patient, what are the predictors of vision, because you have to counsel the patient. You have to be very careful in case selection. Just the presence of VMT does not give you a license to operate. You should be sure that the vision loss is because of the current problem. So if the patient has old records, that will help you. and then you can attribute the present visual complaints to the present problem. So focal adhesion usually have lower preoperative visual acuity. The final visual acuity is similar between groups. So the magnitude of visual acuity improvement appears to be better in focal cases. And broad VMT, they have a longer symptom duration and prolonged macular thickness, usually related to ERM. And the new classification has come on the macular holes. Stage 0 is vitreomacular adhesion. Stage 1 is vitreomacular traction. Stage 2 is small hole less than 250 microns or medium 250 to 400. It's a full thickness hole with still attachment of the vitreous, that is VMT. Stage 3 is medium or large hole more than 400 microns with VMT, and the stage 4 is small, medium or large full thickness macular hole without VMT. Why it is important to classify this way? Because it has surgical importance. Small macular holes less than 250 microns, there is a very high success rate of closure with just vitrectomy. Medium holes 250 to 400 microns, high rate of anatomic closure with complete removal of hyaloid with or without ILM peeling. And large macular holes more than 400 microns, in such cases it is mandatory or desirable that you do ILM peeling. So that's why the importance of this classification. I think this also I'll skip. I think Dr. Chatra is going to cover the... Okay, so to conclude, anomalous PVD can cause multiple problems. SD-OCT is necessary to diagnose, treat, follow up in the various VIP problems, and pars plana vitrectomy remains the primary treatment option for many patients with VMT. Thanks.